So I will talk mainly on large anterior inferior glenoid rim fractures that occur either with a direct blow to the shoulder or with an associated shoulder dislocation and are more or less displaced. So the question is, can we treat these fractures non-operatively? This is a 68-year-old female. She came 4 weeks after the injury. We treated her conservatively, and that's her result at 40 months with healed fracture, little step off, but excellent function. She is pain-free. This is not a single case. If you look in the literature, you actually find 2 studies, one from the Balgris group and one from our group. We looked at non-operative treatment in patients with an average age around 53, 57 in these groups. Follow-up pretty long, between 26 to 67 months. And if you look at the scoring system, subjective shoulder value and constant scores, they're actually pretty good. And it's independent of the step-off that you diagnose during the initial CT evaluation. So in the Balgris group, there was a step-off between 0.5 and 11 millimeters, and in our cases between 0 and 6 millimeters. So pretty good results with a very low, let's say, osteoarthritis rate, 2 and 3 cases. So the prerequisite is that you have a centered humeral head. Then you can treat these injuries non-operatively, at least in a group of patients that is on average above 50 years of age. Can you improve the position of the fragment? It seems to be that if you place a little bit external rotation, like Ichi Itoe has described for the Bankart lesions, you can even improve the position of the glenoid fragment, and that might optimize your non-operative treatment. What is if the head is decentered? If you have a patient like this, she's 73 years old. Obviously, the head is decentered with a glenoid rim fracture. If you treat this patient non-operatively, and this was the wish of the patient, this is 12 months follow-up, the patient usually goes rapidly into instability arthropathy. And although the fragment is healed in a more or less acceptable position. But it's interesting, some patients are not really unhappy. So that's 12 months, she has a good function, she's pain-free, although she has cross instability arthropathy. How do we treat these patients when they have a displaced fracture, or if you go for an operative treatment if the head is decentered? As you can see here, these are techniques from the open approaches with 2 screws, or when the suture anchors came on the market, we've been using suture anchors. This was almost reaching now 20 years ago, and Dirk Meyer, he actually described first-time pins to fix these fractures to avoid, obviously, screw problems and problems with the anchors, because with the anchors, as you can see here, with open techniques, the sutures were going over the cartilage. The results are not so bad. If you look in the literature, open techniques with subscapularis takedown, pretty high clinical results, pretty high scores. Osteoarthritis rate is between 16 to 23%. However, the revision rate is quite high in these patients, between 60 and 27%. And the reason for revision mostly were problems with the metal screws. So either metal overhang, metal impingement leading to destruction of the humeral head. I'll show you one case, 65-year-old lady that was treated somewhere with 2 screws, glenoid rim fracture, actually arthroscopically. In this case, it was not done open, but you see the overhang of the screws. And these screws have created impingement of the humeral head. And when you revise these patients, you see these massive destruction of the humeral head on the lower right. That can, of course, lead to a premature degenerative joint disease. Another problem is when you do it open, you need to somehow go through the subscap. Either you take it down completely, you do an L-shaped tenotomy, or do a split. And we looked at patients where we did a complete tenotomy or even L-shaped tenotomy. And we found that even if you reattach the subscap after your surgery, and even if it heals, you get fatty infiltration or atrophy of the upper subscapularis muscle. So this is something you should take into account when operating these patients with an open approach. So it's an iatrogenic lesion of the subscapularis in this particular group of patients. And it has been proven if you do an open approach, it leads to internal rotation deficit in around, this cohort, around 40% of patients. So it makes sense if you go for operation to do it arthroscopically. The first techniques were introduced using the metal fixation, as you've seen with an open approach. In 2009, we started to use bioabsorbable screws. And obviously there are other techniques like suture anchors, the Sugaya technique or the bone bridge technique published by Peter Millett that are available. I show you our technique, what we've been using now for a couple of years. It works very well. We published this in JBJS in 2019, and it's basically a combination of osteochondral darts plus knotless anchors. And over the years, we in fact tried everything. We tried metal, we tried suture anchors, we tried bioabsorbable screws, but at the end, we stick to this kind of procedure that you will see.
Video is not, I think, working.
Do you hear the audio actually?
Yeah, audio we can hear, but video is not.
No, there is no video. It's the video. Sorry about this. So here you see the fracture. We are now in a lateral decubitus position. We have basically an anterior main fragment and an inferior axillary fragment. So first what we do, we detach the anterior main fragment because it was already healed. This fracture was almost 3 weeks out. You see that the anterior fragment is almost always attached to the labrum. As you can see here, the labral ring is intact, so we use a pulling suture. And now we debride the fracture site. Here you have the axillary fragment, and this fragment is also almost always attached to the inferior labrum. So if you have prepared your fracture site, you flip the fragment back into position, as you can see here. And again, we use pulling sutures. These sutures are placed through the labrum. We use a so-called fiber wire loop technique because they help us to hold these fragments in position. And now you see we place a K-wire percutaneously to hold the inferior fragment in place. With this, we already recreating the shape and the configuration of the glenoid. And now we fix the labrum superiorly. Before we do anything else to the fragments, we fix the superior labrum because fixing the superior labrum gives you already a primary stability of the fracture site. And now, as you can see here, we are placing these darts, these osteochondral darts. And the nice thing is you don't have to be parallel compared to metal screws. You can actually go into the cartilage very close to the labrum and you drill. And then you place these darts and you insert the darts into the fracture site. Obviously, you cannot see the darts here because they are all inside this guiding device. And the nice thing is you can use 3 to 4 darts and gain additional stability of the fragment. As you can see here, we're using a posterolateral portal to place another fiber wire suture through the inferior capsule because you see here the labrum and the capsule is detached from the inferior glenoid, so we need to fix this. And that's best done by a posterior lateral portal. We now place a suture, knotless anchor, and we fix the inferior fragment. And again, as you can see here with this technique, you create additional stability to the fracture site. So it's a kind of a combination of osseous fixation and soft tissue fixation to use the advantages of ligamentotaxis and get additional compression from the labral reconstruction. And so as you can see here, that's now the final construct, pretty stable with around 4 pins or darts, and 3 or 4 suture knotless anchors with fiber wires. Looking at the results of arthroscopic techniques, they are also very good. There are a couple of studies published. The arthritis rate is almost the same as an open approach. However, the revision rate is much lower. And the reason why the revision rate is much lower, because there are less metal implants being used for the arthroscopic approach. That's a very simple explanation. So to summarize, non-operative versus surgical treatment of these fractures, you can get good to excellent results using both approaches. The comparable rate of osteoarthritis, non-operative treatment requires a centered humeral head on the true AP radiograph. If you operate these cases arthroscopically, you obviously have less subscapularis morbidity, and there's a lower revision rate using arthroscopic techniques. However, there is a bias, as you have seen, that less metallic screws have been used for arthroscopic approaches compared to open. And we truly believe that for these kind of injuries, absorbable implants tend to be the future. Thank you very much.